For a long time, we've been trying to make improvements in the treatment of urothelial cancer patients. MVAC has remained the standard, and recently, with the addition of immunotherapy to our armamentarium, we thought, could there be different ways of giving immunotherapy with chemotherapy to improve patient outcomes? My talk at the Bladder meeting was to discuss the different ways that we are combining, sequencing, or using maintenance strategies of immune checkpoint inhibitors with systemic chemotherapy. The long-term standard has been the use of cisplatin or carboplatin in the frontline setting, followed by second-line treatment with checkpoint inhibitors at the time of progression. And we've seen durable response and survival in patients treated with this strategy and have level 1 evidence supporting immune checkpoint inhibitors use in the second-line treatment. Now, with two great standards, we thought, could these two standards go well together? Could we combine them and enhance the effects in the frontline setting? Some of the first data that became available was last year at ESMO with the IMvigor 130 trial looking at chemotherapy combined with atezolizumab in patients with metastatic urothelial cancer. While that trial did show evidence of an improvement in progression-free survival, we have not yet seen this translate to a significant improvement in overall survival. There's also another trial of pembrolizumab that was funded by Merck that unfortunately was a negative trial combining chemotherapy with an immune checkpoint inhibitor. That being said, there's additional chemotherapy options that are being combined with checkpoint inhibition, including Enfortumab vedotin with pembrolizumab, which at least based on an early report of a small trial showed a response rate in upwards of 60 to 70% of patients. So perhaps finding a better chemotherapy option or less myelosuppressive option will be better at enhancing the efficacy of both the chemotherapy and the immunotherapy. But most recently, there's been a new question raised. What about maintenance treatment? And we saw evidence of a survival benefit when avelumab was given immediately following response, which was counted as stable disease or better for metastatic urothelial cancer. And that trial showed a significant improvement in overall survival compared to patients who did not receive treatment with avelumab in the maintenance strategy. And at least in the United States, this has resulted in the frontline approval of avelumab as a maintenance strategy for urothelial cancer. However, we do not yet know, is it for sure that we must give immunotherapy in the maintenance setting, or could we wait to time of progression like the pembrolizumab data has shown? Matt Galsky had some data where he did maintenance therapy with pembrolizumab, either immediately upon response or at the time of progression, and did not see a survival benefit. Now, we could argue, could there be differences amongst immune checkpoint inhibitors? Is avelumab better than pembrolizumab in the maintenance setting? Or is this trial a sign of what happens when you compare patients who ever received immunotherapy or never received immunotherapy? At the moment, I think we have two great standards. We can give immunotherapy, such as avelumab, in the maintenance setting in patients in first response, or we could wait until the time of progression and give immune checkpoint inhibitors at that time as well. And only time will tell which one will stand as the long-term strategy for the treatment of urothelial cancer patients.